One of the things you don't want to exceed more than 10 cc's of foam. That has we don't have a guideline in US since it's still off-label, but the European Phlebology Society has given some guidelines in terms of the quantity that you should inject, not more than 10 cc of foam, not 10 cc of solution, but the foam, so it cuts down the amount of complications that you can have. It does travel all over the body. It can go into ophthalmic arteries, and you can have migraines. Asthma can be made worse, but however, but for those few little things, it's quite simple. Of course, whenever a technique becomes simple, a lot of people try to do this, and therefore you do have complications if you're not careful. As you can see the foam coming out nicely, and I'm pulling it out, and I'm injecting the second syringe. As you can see, this is where the foam is stopped nicely. And you'll also see a little distally that the foam gets into some of the abnormal veins also. You can see them going out. Anyhow, this is the ultrasound done immediately after. You can see the blood going into the epigastric vein, but nothing is going in there. And this is my commonest dressing. It's a Cortex pad. I put two together. It sticks very well because they have a sticking surface just for me. And with the Coban, just to keep the vena compressed, and we'll put the stockings on top. When you see the lady, look at their legs, and it's really nasty looking leg, and a very elderly woman. And so somebody 87 years old, you can do something very simple without any anesthesia. Now, it was done in 2005, so almost 6 years ago, and you can see this is just a month after the procedure. The vein wall is thickened, but there's no blood going in there. This is almost 2 months after, and once again you can see the vein is non-compressible. This is the saphenous vein, and in a longitudinal fashion you can see the wall is nicely thickened, and there won't be any flow through that. You can see the flow going to the epigastric. This is what I've really kind of talked about, the physiological drainage still exists. This 3 months later, you can see the vein is getting even smaller in size, and going into the epigastric vein. So that, and as you can see, there's no reflex anymore. And this is almost 4 or 5 months later, and the vein is almost dead. Really, it's become like a cord. This is very similar to what happens with the. There's one more picture here later. Then, yeah, this is a year later, and we changed the machines at the time, so I'm not able to show you. It's very similar, but once again, you can see how the saphenous vein is almost non-existent. You can't even find where it is. I think this is probably the GSV here, and there's no flow in it. So the primary occlusion is better than 80% most published data, and initial failure can be treated with repeat injection. You may have some small areas where the perforates are coming and that may not close. It's so easy to go ahead and puncture that area and give a little bit more foam, and so the final results are over 95%. Complications are rare. Occasional DVT of the muscular veins have been reported, making the incidence to be less than 0.03%. And of course, you can wear a red shoe after that. Ophthalmic migraine, visual disorders such as transient hemianopia, dry cough are more common. In fact, John Bergen, who's a big proponent of this, had an ophthalmologist wife, and he was doing it. And about 15 minutes later, the lady was completely blind on one eye. He really scared. But anyway, it clears up. But we have no idea how it gets into those areas. But if you start doing even a transcranial Doppler on these patients, you can see some hits going on. But unlike an embolus, this is minute CO2 bubbles, so it dissolves very fast without leaving any permanent damages. Now, we know about PFO. There have been a case reported as death. This particular case was very interesting. It was done in the UK. It was done by a dermatologist who was injecting about 20 cc's of foam in a branch vein of saphenous. They don't do it the way I did. They actually inject it into the peripheral vein and then massage it up with the ultrasound probe. So when you massage it, there's a chance it can go into perforators more than the way I do it. The way I do it, why I'm saying different is because the hemodynamics is such, the blood has a tendency only to go from superficial vein to the deep and not otherwise. And also only to the incompetent. perforates. So when you do it this way, it has a tendency to just stay in the vein that you're injecting. On the other hand, if you're trying to forcefully massage it, it has a tendency to go to the deep system. Once it goes to the deep system, it's going to go really fast. So the patient basically started having symptoms of stroke as they were doing it. The technician, ultrasound tech, was really smart. They took the probe and put it in the carotid artery. You can see all these foams going up there. And of course, I think the doctor died too, but you do have to be careful. Just because it's simple, you just can't take the case. The success of foam is attributed to prolonged contact with the vein wall and the endothelium. This leads to subendothelial layer exposure with irreversible venous fibrosis. So really, it works very well. I probably use it at least about 10-15 times a week in multiple areas. Now, we don't use it for great saphenous vein unless there's a specific case like this, because we don't get paid. So the patient will have to pay for it because the insurance still thinks it's expensive. Thank you.